The title of our video is Facilitating Complete Excision of FIGO2 Fibroids at the Time of Hysteroscopic Resection, a three-step process. The authors are listed, and we're coming out of Chicago at Northwestern. We have no disclosures that are pertinent to our presentation. Fibroids have been resected hysteroscopically for the past 25 to 30 years with success, primarily with FIGO0 and FIGO1 fibroids, but FIGO2 fibroids remain challenging given the significant intramyometrial residual fibroid tissue that can exist. As a result, we sought out the feasibility of using dilute carboprost to promote the intramural portion of the fibroid to migrate into the cavity. IRB approval was sought. The hysteroscopic morcellator made by Hologic was used. Dilute hemabate 10 micrograms per ml was used, and that was instilled using an endoscopic needle made by Boston Scientific. The three-step process included step 1, resecting the intracavitary portion of the fibroid. Step 2, injecting dilute hemabate at the fibroid endometrial junction. And step 3, continuing to resect the fibroid as it migrated. Here's an example of a fibroid that was 4.5 centimeters, 2 centimeters in the cavity of the uterus, and 2.5 centimeters in the myometrium, extending to within 3 millimeters of the serosa. This portion should be familiar. We used the largest of the hysteroscopic morcellator devices to resect the fibroid to its base. This continued in the usual fashion, attempting to stay inside the capsule in order to maintain hemostasis. We are now at the base of the fibroid, and you can see there's still a significant amount of fibroid in the myometrium. At this point, we swapped out the MyoSure handpiece with the needle. Again, the needle made by Boston Scientific, and we injected at the intramyometrial junction, promoting migration of the fibroid. We injected here on the left, to the left of the defect, and also to the right of the defect. Almost immediately, the fibroid starts to migrate. We quickly swapped out the needle for the hysteroscopic morcellator, and you can see already within those few seconds, the fibroid is extending into the cavity of the uterus. Quickly, we started resecting in the usual fashion, proceeding side to side, keeping the tissue well engaged in the hysteroscopic opening, and came to the base of the fibroid. The fibroid continues to migrate as we are resecting, allowing us to continue to resect in a steady fashion. We avoid any damage to the surrounding endometrium and normal myometrium. You can see here the base has been completely resected, and we see normal myometrium below it. Here's another patient who had a fundal adhesion and also a FIGO2, possibly FIGO3 fibroid just to the left. After the fundal adhesion was lysed, the fibroid still was not very visible. Obviously, we could have started with a resectoscope, but we didn't want to cause myometrial injury. And you can see the os is well seen. So here we're instilling dilute hemabate to the side of the fibroid. The key is not to inject too much because the fibroid tends to migrate very quickly. So rapidly we switch out the needle with a hysteroscopic morcellator, and you can see the fibroid is already extending into the cavity of the uterus, really just bulging into the cavity of the uterus, particularly when the pressure is reduced. Once the hysteroscopic morcellator is in place, we resected the fibroid, and it continued to migrate as we resected. Again, staying inside the capsule in order to maintain hemostasis. Within minutes, the fibroid was resected partially, and just a few minutes later, the fibroid was resected completely. And you can see here, we're now at the base of the fibroid, and all we see is normal myometrium. So the three steps are resect the portion that's in the cavity that's visible, then inject dilute hemabate at the fibroid endometrial junction, and then continue resecting the fibroid during the migration process. Here you can see fibroids that were type 2 that were resected completely on 3D and 2D ultrasound. In conclusion, hysteroscopic administered prostaglandin F2 alpha appears to be a feasible method of facilitating complete removal of FIGO2 fibroids, reducing the need for additional procedures. Thank you.